We have taken 13 Asian countries, 62 co-investigators. We defined ALI, that is acute liver injury, as bilirubin more than 3, enzymes of any AST, ALT, SAP or GGT that increased more than 2 times the upper limit, INR more than 1.5 with the previously normal liver parameters. That is called acute liver injury. New onset is defined as the above definition has been fulfilled, and this is upper when there is baseline report is normal. That means at admission this report is normal. They develop a liver injury during the hospital stay. And when you go to the patient data, we have considered the data is 185 with cirrhosis, and who about 20% of liver injury at admission, and cumulative they develop 32%. Additional 12% has developed in a cirrhosis. Those having without cirrhosis. And cirrhosis 43 peoples, of compensated 25, the liver injury is 16%, but in hospital become 48%. So here you can see that if is compensated, they get an acute liver injury because of COVID, that is more over the course of hospital stay. It is already decompensated. Then nearly 55% from the beginning is liver injury. And this liver injury is on the above the baseline what they may have because of the decompensation. If they have a decompensated cirrhosis, they have deranged enzymes, then it got further increased in 55% patients with COVID infection. And during in hospital, there is little bit of decline because the number is very less. So hence we are not able to get an accurate result. And if you see the patients included are divided as CLD with cirrhosis and those in cirrhosis. So CLD cirrhosis is F4, F3 fibrosis, fibrosis high, varices, CT showing the pictures of typical cirrhosis. Whereas no cirrhosis is up to grade 2 fibrosis if they have a biopsy proven, NAS, autoimmune hepatitis, these are the group of the patients. And we can see here the most common etiology in our cohort is coming to be among the cirrhosis is viral, whereas in non-cirrhosis, it is most common coming as the NAS group. So these are the group of the patients. And at admission, COVID severe as defined by the WHO definition, it is close to 18% in cirrhosis, 12% in non-cirrhotic. So in this study, both are equally not significant different much. When you go for the bilirubin is little bit on the higher side, and as we discussed already, the acute liver injury at admission and worsening decompensation are significantly high in presence of cirrhosis. Then treatments, this treatment is across the Asia Pacific. So we get varied treatment. You can see all the drugs, SUKS and azathioprine, antiviral drugs, steroids, IVIG, plasma exchange, convalescent plasma. So these are used varily in different way. So we just want a comparison, but I think this is not to be considered as important. Then when you think that COVID-related complications, be it respiratory failure, renal failure or shock, they are more in presence of cirrhosis, and need of ICU care, liver-related complications are high when in presence of a cirrhosis. Then here we can see here those survived and the dead and how the dynamics of lab parameters are going on. So this is the bilirubin. You can see that this is the level of bilirubin at baseline. This is the maximum, and this is at discharge. So survivors, this shows a little bit difference, 1.1.7. Whereas among the non-survivors, there is a sharp rise. Bilirubin 4, it is gone up to 11. And at the death or the end of the natural history, it is still on the higher side. And the similar trend also shown by the enzymes. So we have taken the ratio of AST and ALT. This is also showing that it is also different way. Similarly, here this finding is very important. We have done the R value, that is ALT and SAP ratio. So when you consider this ALT by alkaline phosphatase ratio, when this ALT is on the higher side, alkaline phosphatase is on the lower side, that means liver injury is more from the parenchymal, the recovery is good. But when this value is low, that means alkaline phosphatase is on the higher side, that is a cholestatic pattern is happening, then survival is poor. And here you can see, we done a comparison for the CLD without cirrhosis, CLD without liver injury, cirrhosis, liver injury, or no liver injury. So these are the 4 groups. Overall complication is highest in presence of cirrhosis with liver injury. Liver-related complications are also high in case of cirrhosis with liver injury, and mortality is sharply increased in a cirrhosis with liver injury. And this is the at risk and the events. And here you can see how this COVID is differ. CLD without cirrhosis, severe COVID is happened only 11%. In cirrhosis, 20%. In recombinant cirrhosis, it's further still increased. So this is going parallel to the disease of severity. And similarly, the incidence of liver injury is also higher among the spectrum. CLD without cirrhosis 52, with compensated cirrhosis 64, decompensation is close to 83%. And the CLD with mortality, you can see CLD without cirrhosis mortality is only 2%, cirrhosis 16%, decompensation is 33%, and cirrhosis in general, when you consider for the overall cohort, it is coming very high. And this you can see the mortality curve, which shows the patients in relation to CTP score. So from the CTP score, we have taken a ROC cutoff value that comes to be 9. If CTP is 9 or above, the mortality is sharply on the higher side. Survival is close to only less than 5%. If CTP is more than 9, survival is better. So from this study, we found that those having CLD without cirrhosis, mostly dominated by NASH, diabetes predisposes to the liver injury, but not a predictor for mortality. 43% have liver injury, and commonality is ALI, and the recovery is very good. If it is a cirrhosis, the predominant etiology in Asia is viral. Obesity presence increases more injury. Nearly 2/3 have a liver injury, and 20% goes into worsening of liver disease, either SCLF in 11%, acute decompensation and 9%, as per the APASL definition. And this dynamic changes in bilirubin and the ratio of AST/LT in predicting survival. And they have a higher complications and mortality, which is close to 16%. So this study has highlights what is added the value, that it is a survey including diverse data across the 13 ASEAN countries, 62 investigators. CLD increases the risk of severity with COVID. The risk of acute liver injury is increases among those having cirrhosis and more with decompensation across the spectrum. Diabetes increases the liver injury among the CLD, those are not having cirrhosis. Obesity increases mortality with COVID in cirrhosis, and ALI leads to the more common mortality in second and third week, and recovery is happening better way. And CTP score 9 is what we need to go high AST/LT ratio to consider, and a rising bilirubin. These are the parameters that predict the poor outcome. And the mortality is 16% in cirrhosis, which is more than the general population. So the study has suggested that SARS-CoV-2 precipitates significant liver injury. It causes decompensation nearly 1/5. This leads to worsening clinical status who are already decompensated. And this patient should be prognosticated from the beginning, depending upon comorbidities, diabetes and obesity, with a CTP score, high AST/LT, and the course of bilirubin. And this is the study which we want to discuss. And there's few other data which I have done from the APASL, but if the chair permits, we'll discuss. Otherwise, we'll close here. Thank you.
Well, this is the excellent studies. And in fact, I'd like to congratulate the APASL COVID task force. Well, during the periods of the difficult times of the COVID, we gathered together and get this data assembled to facilitate our management with patients in hepatology discipline. Ashok, you mentioned about the studies, the APASL. We have a monkey survey. We have very limited resources, and I think that's really the brotherhood we share in Asia Pacific regions. And and really congratulate your efforts of doing all the analysis and so on. You mentioned about the alkaline phosphatase, if there is more indicating more the ductal injuries have a worse prognosis. So what is your hypothesis behind this, having the same COVID-19 infections?
Yeah. So COVID has two ways. It causes hepatocellular injury and biliary canalicular injury. So if AST and ALT are rising, that means it is ischemic injury or a direct cytopathic injury. Whereas if you think of a SAPS, it is on the higher side, that is R value is going up, alkaline phosphate is high. It is one because of the biliary duct injury. Then second, this is also related to disease per se, COVID related, some of the drugs also, which causes more in that way. And third, it is the late phase of a critical illness. As we see that cholangiolitis or cholangial changes are more prone in the towards the end stage of the liver disease for the critical ill cirrhotics. So in that we think that there is some bile duct injury because of the COVID. Then that it is multifactor related to drugs, infection, or sepsis. And then third is being a cirrhotic or being a CLD. Towards the end, they develop a serious complications in terms of worsening of the disease. Hence, the last product is in terms of SAPS on the higher side. So this is what I can say from the three factors.
Right. Do you plan to have any follow-up studies on these patients who suffer from the COVID liver injury with ACLF, which is an important etiology for ACLF, which added to our understandings? And I hope we are not going to see another SARS 3.0. But just in case it happens, I hope we will be able to manage our patients in a better manner.
Yeah, so that is a nice one. I think we have not done any follow-up. If you all like, I think whatever patients, I think we have across the Asia collected close to 1100 patients data. So we can rerun that monkey survey to see the follow-ups. We can do it, but we don't have any data right now.
You have 200 something patients. So Diana, so you want to add something?
Yes, yes, Professor. The COVID virus uses ACE receptors. And we know for a fact that there are a lot of ACE expression or receptors in the hepatocyte, but more in the cholangiocytes. And that is why most of our patients would present with elevated alkaline phos rather than hepatocellular. The hepatocellular alkaline phos, the hepatocellular damage that we have seems to be related more to a cytokine storm or probably those that are related to the drugs. It would be interesting, Professor, if you would be able to identify, because at that time, it is actually not the drugs right now, the molnupiravir or the Paxlovid that is being given, but the Lito and the ritonavir, which are both hepatotoxic. So I guess that has to be also considered when we identify patients who have the risk to develop liver injury. What I'm interested to ask Professor Lau is, are there patients who were compensated that became decompensated on COVID? Because that seems to be the next paper that we will discuss, wherein those patients who actually are compensated develop decomp when they actually develop a severe COVID.
I think that Ashok is the one you want to ask. He is the one who is presenting the paper. So
yes.
We are all involved in all the work with
Yes.
ACLF. Ashok, would you like to respond to the Diana's comments or questions?
Yeah, thank you, Dr. Diana. So I think I have shown here around 20%. Malab, 1 in 5 is getting some worsening of liver disease. Some develop ACLF around 11%. And another 9, you can say nearly 50-50. Nearly half develops ACLF and 50 goes to decompensation is there. So I think, and we have shown a correlation to the parallel background liver disease. If his MELD score is on the higher side, if his bilirubin or AST. So two things, it is your baseline disease predicts whether they will develop ACLF or acute decompensation. And then over the time, how they behave. If AST-LD ratio is going up, CAP-GD ratio is going down, if bilirubin is rapidly rising. So we have data on day 1, day 4, and day 7. So I think this way we can see how these people are going to worsen, but the pathophysiology leading to how they fell is mostly the systemic inflammation. Cytopathic injury may be part of, but it mostly be bystander cytokine storm leading to immunomediated injury. These are the two pathophysiology we can say for these recommendations.
Thank you, Professor. I have one last question, Professor George. Is it okay? I have you seen? I have seen, this is in the real world scenario, wherein a family was infected with COVID, and yet the patient with viral hepatitis B did not get infected. I was wondering whether there is sort of a, because Professor, remember, we had the so-called survival of the fittest virus in the body. So is that possible that one virus only actually survives? That's why I said, is there a sort of mechanism that can explain why those patients with viral hepatitis B do not seem to be as infected as those with NASH? Because NASH is also in the next study that will be presented, most of these patients have NASH rather than viral hepatitis B as a background. I was just, it was just a throw-off hypothesis that the survival of the fittest virus will actually be there. Do you see it also in your...
Yeah. Professor Diana, I think our data shows two things. Those having cirrhosis, most common etiology across the ACI is viral in this study. But data is limited only. And when you go to the non-cirrhotic CLD, we found the NASH as the most common.
Yes.
And this data is only when you get a virus patient, then only gone for.
Oh, we got lost.
Yeah. Hello. Sorry.
Yes.
So I think, yeah. So I think now there is no data to suggest. So we can do a meta-analysis of all the published literature. So we can find some of this, but it's a very interesting suggestion. We can think that way, whether one virus infection protects against the other.
Okay. Thank you, Professor.
This is very interesting because you mentioned two mechanisms of liver injury already. One is the virus itself. The other is the cytokine storm related. So the displacements could be more on the viral etiology. And I don't think we have any data on this. Maybe someone can work on the mechanisms for us to understand so that we can manage better patients who suffer from liver diseases during the COVID period. With the time limitations, Diana, could you please
Now,
to the second?
now.
Yes.
Hello. Hello,
Yes.
everyone.
Hey, we have our tech friend here. So,
Thank you very much.
Yes.
Thank you, Ashok. It's a really excellent presentation. Also, the discussions are very, very productive. I think it's very important for the dual viral infections, the mechanism of the clinical symptoms, you know. I think we have to have some further investigations.
Yeah,
I
can complete same thing. Professor Lau, you are expert in B, we can say when our patients having hepatitis B, they get an acute hepatitis E, the DNA get cleared very faster. That is our observation. We are not able to document it, but that is also we have seen. So maybe it is the mechanisms not fine.
Very nice, very good presentations. Diana, could you please proceed?
Yes, thank you, Professor Lau. Our next paper is the effect of COVID-19 on patients with compensated chronic liver disease. This was published in 2020, and I think this has also a lot of citation. May we have our next speaker, please? Professor, hello.
Professor Dr. Xu Jing.
The professor.
Yeah, he is here. He is here.
Okay, thank you.
Yeah, but
There, I saw him. Yes, yes.
are you coming in? Okay.
Maybe we can go for the next one first.
Yeah, we can go for the next one if that is the case.
Okay. Our next speaker is going to talk on the paper on liver injury in a patient with COVID-19, the clinical profiles, CT scan, and the correlation of the severity with liver injury. This is one of the well cited. Okay, I think Professor Xing is here. Hi, sir.
Hi, thank you.
Thank you.
I think maybe something is wrong in the website in China, in mainland China. Zoom sometimes didn't get access, so I just use the website. So I first wait minutes. I show my PPT. Okay. PPT. Okay, can you see my PPT?
Yes, sir.
Okay, thank you so much. Okay, firstly, I thank you so much give my chance to show my research. My title of the research is the liver injury in patients with COVID-19, clinical profiles, CT findings, and their correlations with severities. My name is Yu Hosong from Uni Hospital Tongji Medical College, Huazhong University of Science Technology. My topic is divided 4 sections: 1 section, detections, materials, results, and conclusions. First, we talk about introductions. COVID lines can cause the can damage to many organs, such as lung, liver, heart, kidney, and gastrointestinal tracts. In most of these, COVID lines attack the lung disease. We also see the abnormal liver functions was observed some patients of the COVID-19. The liver biopsy specific with the patients with COVID-19 shows the hepatocyte deteriorations, focal leukocytes, moderate microvascular stenosis, infiltration of the leukocytes into lobular potent areas, sinusoidal congestions. As a rule, CT is widely used in the detector for pneumonias to detect the converting lines. So, but the result is we didn't find the papers about the abdominal CT scan in data. So the aim of our data is to determine the clinical profiles of the patients based on severity gradings, describe the abdominal radiological signs, investigate the correlations of the severity of the clinical profiles and radiological signs. Then we change to the materials and methods.
Professor Song, I think your slides are not moving.
Moving?
Yes.
Slides moving?
There, now it's moving. Okay. Oh, it got lost, sorry. Professor Song, sorry.
Okay, sorry.
Your slides are not moving. Yes.
Okay.
Please share it again.
Okay, sorry. Can you see it again?
Yes. Okay, now we can see it, sir.
Okay. Materials and methods we divide 4 sections: patients selections, medical data collection, and CT techniques. Then we collect the CT image. We imagine processing and analysis the CT image and statistical analysis. Patient selections: the patients with COVID-19 will receive a CT scan and the laboratory examinations within 2 days after administration from January 24th, 2020 to February 17th, 2020. We exclude the patients. The patients received antibiotic treatment for more than 3 days before administrations. CT image, we exclude the patients didn't receive the CT image of abdomen. The patients with hematological malignancies who received chemotherapy was excluded. The patients with severe chronic pulmonary disease was excluded. The patient with chronic liver disease and liver cancer was excluded. 115 patients enrolled. Ordinary case.
Professor Song, it's not moving again.
Okay, sorry.
Can you
I
click
don't know the reason.
there? Maybe you have to click the slideshow under and then.
Okay, sorry.
Yes, thank you.
Because I use the website.
Ah, okay, I understand.
I just use this one, maybe
There,
better.
there. Okay, now, yes.
Maybe better. Okay. We use the ordinary case, severe case, and critical case. Because the minor case don't have the pneumonia, so we just collect the 3 ordinary case, severe case, and critical case. Data collections, we collect the clinical profiles, demographic data, presenting systems and science, medical histories and laboratory tests, and therapeutic process. The importance, we collect the image of CT. First, we collect the chest scan. Chest scan was divided 4 degrees: grade 1 low involvement, grade 0 low involvement, grade 1 less 5% involvement, grade 2 5 to 25 involvement, grade 3 is 26 or 49 involvement, grade 4 40% or 75% involvement, grade 5 is more than 75 involvement. Abdominal CT, we analyze the hematomegaly, periodema, pericholecystic fat stranding, portal lymphadenopathy, biliary ductal dilation ascites. Because we found the liver homocysteine, we qualified the liver to spleen attenuations. We use the region of the interesting areas, 2 in right lobe, 1 in the left liver lobe, 3 region of the interesting in the spleen, the qualifications. Then we change to the results. Results, we divide for 4 sections. 1 section is laboratory test, second 2 case presentations, 3 image findings, 4th is correlations between the clinical profiles and image science. First, we see the laboratory test of the COVID and administrations. We use the red blood cells, white blood cells, and platelet. Most red blood cells, white blood cells, and platelet was in the normal lipids of the most patients. We see the lymphocyte. Lymphocyte decreased. We can see the significance with also with the CD3 positive T cells, CD4 T cells, and CD8 T cells. We can see the significant difference. These are p-values. We can see the significant difference between the ordinary case, severe case, and critical case. We can see lymphocyte decreased significantly in critical case. CD3 T cells decreased significantly, and CD4 and CD8 also decreased in critical cases. So we can conclude the proportion of CD3 positive, CD4 positive cells, CD8 positive cells decrease significantly in critical groups. Then we check the liver functions, renal functions, and CRP. We can see that first we can see ALT, AST, LP, and GGT, and the total bilirubin. Or most of the patients is in the normal limited. We see the albumin decreased in most patients. ANR most in the normals. we can see the urea creatine lines is in normal with. So we assess the CRP. So we get the conclusion most patients have the normal liver functions, most patients have the normal renal functions, but normal, we can CRP, C-reactive proteins highly increased. We can see the abnormal CRP levels was decreased in most patients. We also check the different groups. We can see AST with the different groups. In critical cases, increased AST, observed albumin, we can decrease significantly in critical cases. We can CRP, we can see the increase significantly in critical cases. Before analysis the chest abdominal chest, we can see the case presentations. This criticization is 18 years old with the severe COVID-19. We can see A and B is a chest CT. We can see the grunted glasses opacity, grunt opacity. We cause the partial consolidations, and the pleural effusion, small amount of pleural effusions. We consider the liver hypertensities, homogeneous of the liver hypertensities. The liver spleen attenuation ratio is 0.99. We can see the last cases, the critical cases, for the 51 years old male patients. A and B is a chest CT. We can see grasp opacities and pleural effusion. We also see consolidations. We can see obviously consolidations. The semi-quantitative scoring of the lung is 22. C and D is the abdominal CT scan. We can see the liver hypertensities. The liver and spleen attenuation ratio is 0.4. We also see we can enlargement of the gallbladder. We can see the pericholocystic fat stranding. I will see this well. Fat stranding. So we analyze the data. Radiology findings of patients in the patients of COVID-19. First, we use the radiological feature of the abdominal CT, liver hyperdensities in 26 patients. Pericarditis fat stranding is the 21st patient. We can also see the difference between the liver hypertensity. The difference, we can see the difference between among the groups. In critical cases, we can 58% of people, we can see the liver hypersensitivity. Then we quantify the liver quantitative analysis of liver hypertension. The liver attention ratios, the value is 1.20. In critical cases, is 1.001 in these patients. We also see the percentage of the less than liver spleen attention ratios. That's the one that we can see critical cases 47% with the liver spleen attention ratios. This is that. We also reach radical failure with chest CTs. The CT score involvement 11 in critical cases. 22. Pleural effusion here. The correlations of the severe grade clinical profiles of radiology cases the patients. Do you see the PPT? Can you see the PPT? Okay, okay. With the same quantitative CT score of the primary visions, we can see these positive correlations of the AST, ALP, TGT, and the total bilirubin, and LB, and PT always also is the CRP, always it also positive with the CD qualifies the liver to spleen attachment ratios. Another way determines the relationship of the severity of the COVID-19 liver function test. We can see the AST, albumin, and CRP, and CD qualification of the liver spleen attenuations. So the Scott's preliminary was associated with liver function test, severity gradings, and CRP. The severities of the COVID-19 correlated with AST, albumin, CRP, and the CD score of the primary CD qualifications of liver spleen ratios. These are special cases. We detect these 16 2 years old female patients with fibrosis. With CT scan was performed the February 12, 16, and February 20 lines and March 6. We can see with the treatment, the primary lesions improved. We can see the liver hypercity on CT scan improved within a short times. So we demonstrated this not caused by the fatty liver. Then we conclude to the conclusions. Conclusions is elevated ALT levels, hyperalbuminemia, increased CRP levels was frequently in the critical cases in patients with COVID-19. Common findings of abnormal CT scan in patients with COVID-19 include the homogeneous, heterogeneous liver hypersensitivity, and pericholecystite finding, fat stranding. The severity of COVID-19 patients correlated with the AST, albumin, CRP, CD scoring of the primary lesions, CD qualification of liver spleen ratios. This was helped identification high-risk patients. Thank you for your attention. Okay, my PPT is finished.
Thank you very much, Professor Song. Are there any questions or feedback? I think he has elaborated on the role of CT scan and the clinical profiles, which actually are not different from the. We have a question here from Professor Omata. Does COVID replicate in the hepatocyte? That would be interesting. Because they have said that because the virus is shed in the diarrhea, they usually present with diarrhea. They said that COVID does replicate in the intestinal tract. What do you think, Professor, about COVID replicating in the hepatocyte? The question also by Professor Omata is, does hepatocyte express the ACE receptors? Yes, I mentioned that there was a study that about 2.6% of the hepatocyte does express the ACE receptors, but about 60%, that's 59.7, are the ones seen in cholangiocytes. That's why most of these patients do present with cholestatic jaundice in some scenarios. How can you discuss viral interactions without dual viral replications in a cell? So, Professor Zhong, do you have any answer on that?
Pardon, please. I didn't, because
sorry.
the website.
Yes, okay.
Pardon, please.
Yes, first, do you think the hepatocytes does replicate in the COVID replicates in the hepatocyte?
I don't know.
I think there's no data on that. I also tried to
I have no data. I have no data.
These
are retrospective studies.
Yes.
I just collected the CT scan.
Yes. Based on your study, if your patient does present with, I noticed that in your scenario, you do not use any more chest X-ray, but CT scan, correct?
Yes, CT scan.
Is there a reason for doing that, sir? Because in resource-limited countries, CT scan might not be available. And during COVID, I think it's easier to do a chest X-ray than a CT scan because you actually have a more prolific number of people working for a CT scan. So do you think, Professor, that why do you think did you in the China guidelines? I know I read the China guidelines because we were using that as our parameter here in the Philippines. Why was there a reason to use CT scan rather than chest X-ray? Because is it because you miss out on a lot of ground glass densities compared from a chest X-ray and CT scan?
I didn't compare the X-rays and the CT scan because this study is performed in 3 years old. Now, in the 3 years before the 3 years ago, COVID-19 is very serious in China. So if the patients suspect the patients with the COVID lines, we always receive the CT scan. But now, most of the patients with the COVID lines is mild. Most patients didn't receive the CT scan, didn't receive the X-ray scan.
Because I read your guideline in China that there are 2 ways. You have one, once your patient is diagnosed with COVID, you go to a isolation, or those with fever goes to the hospital, correct? Therefore,
most patients not in hospital. This is 2 years ago or 3 years ago.
This is a very good comment because I think that the COVID severity, it has markedly reduced with the vaccinations and all the experience and the herd immunity. And the guidelines, I think Professor Pawai has mentioned was in the past 2-3 years ago when we are having a severe blow from COVID-19, causing a lot of casualty, and the vaccine is not catching up and so on. But I really appreciate the presentations on the CT scans, and there are lots to learn. And obviously, we also need to know about the CT scan protocol you have been using, whether it is standardized, and whether you would prefer just a planned CT or a CT with contrast. Would that make any difference? And this is something we need to learn from your vast experience on the use of imaging technology.
I just used thank you for Professor Do. I just use the plan CT because in 3 years ago we didn't do the contrast CT because a lot of patients receive the CT scan, so we just use the plan CT. Okay.
Yes. Professor Mata is raising the issues about hepatocytes, whether the SARS virus can enter. And I think that the ACE2 receptor has been demonstrated in the hepatocytes in papers published in Journal Hepatology. But then the question is we don't have a cell culture system to understand the viral interactions of hepatitis B, as pointed out in this webinar, and whether how it could interact with the coronavirus inside the hepatocytes. Having said that, well, the pandemic is over, and maybe some laboratory works needs to be done. If we can have a cell culture model to allow the replications of both viruses, especially we can allow the entry of the virus. Yes, is that the questions, Professor Mata?
Yes, no, let me describe my experiences, because there is a classical COVID-19, I mean, not the COVID-19, classical COVID infection. And then interesting part in the epidemics of COVID-19, new COVID, no classical COVID was found in a hospital. So that case, they are residing in the same cell. So there must be the, mutual suppressions, interactions. But as I mentioned, if it's a hepatocytes, we don't really know whether they can coexist. Without coexisting, it's not possible. As you know, hepatitis A virus, B virus coexisting. So I think we should be a bit cautious about that. That's my comment.
This is a very good question. So I don't think there's any data existing. And unfortunately, they will rely on the liver biopsy and to do the staining inside the hepatocytes, which can be done with the technology platforms we have. But I'm not aware of any publications on this aspect of coexistence of two viruses in the same liver cells and how they interact with each other.
We try to visualize the antigen in the lung tissue, and we could do it. But in the same patient, we tried that in the hepatocyte. We couldn't do that. So far, we don't have a data. But that doesn't not necessarily exclude the possibility of a minute amount of the replications.
This is certainly an excellent comment. But with the time limitations, shall we move on to our next talk and to be the chaired by our next moderator? Is Professor Tawandi here? If not, Yushumi, can you put on the video pre-recording the presentations for our second papers? Yushumi?
Yes, sir. First of all, thank you very much for your introduction. Today is the Middle of Autumn Festival, and I wish all professors a happy holiday. I'm very grateful to the Asia Pacific Association for the Study of the Liver for paying attention to my team's article. Effect of COVID-19 on patients with compensated chronic liver disease. And I'm honored that our article can be rated as best publication in Hepatology International ACLF. Next, let me share this article with you. First, let's look at the research background. With the rapid expanding COVID-19 pandemic, liver injury has been increasingly recognized as part of the clinical picture. The underlying mechanism of liver injury is not clear. Hepatitis with elevation of serum ALT has been reported to occur in up to half of the patients infected by SARS-CoV-2. The severity and frequency of liver injury correlated to the severity of COVID-19. Those with disease progression suffered from severe liver injury more frequently. A phenomenon termed cytokine storm, characterized by markedly elevated plasma levels of pro-inflammatory cytokines, has been associated with severe COVID-19. This cytokine storm may be related to liver injury. On the other hand, direct cytopathic damage by the SARS-CoV-2 is also possible, as there are receptors ACE2 in the liver, especially in the bile duct cells. Some drugs for COVID-19 may be also cause liver damage in patients. Globally, there is an increasing prevalence of chronic liver disease with underlying advanced fibrosis or cirrhosis due to chronic hepatitis B or C infection, and recently non-alcoholic and alcoholic fatty liver. It is also unknown whether the disturbance of immunity related to COVID-19 will have an effect on hepatitis B or C infection, leading to reactivation. Many of these CLD patients are silent in a compensated state. So far, there is a lack of reports on acute or chronic liver failure in COVID-19 patients with compensated CLD. Based on above background, this study was carried out. The purpose is to examine the incidence of liver injury and ACLF in COVID-19 patients with pre-existing compensated CLD. Research methods. Diagnosis and grouping of patients. The presence of SARS-CoV-2 in respiratory specimens was confirmed using RT-PCR assay by all local municipal CDC. All COVID-19 patients without CLD admitted to these two hospitals during the same period as the COVID-19 patients with CLD were used for comparisons. These COVID-19 patients were followed up till discharged with recovery or death. Data collection. All the patients' information were collected from medical records. All patients had ALT, AST, TBIL, ALP, and GGT on admission and then at least twice weekly till last follow-up. Method was identified as hepatic steatosis index more than 36 points and or by abdominal ultrasound examination. Chronic hepatitis B was defined as HBsAg positive for at least 6 months. CLD was defined as FIB4 greater than 3.25 or APRI greater than 1.5 or CHB, or subjects with HSI greater than 36 and BOD score 2 to 4. ACLF was defined by APASL criteria, jaundice, and or coagulopathy complicated within 4 weeks by ascites or encephalopathy. Statistical analysis. Continuously variables were expressed as mean SD and compared using students' t-test, or median and compared with Mann-Whitney test. Categorical variables were presented as numbers, percentage, and compared by the chi-square test or Fisher's exact test. A p-value less than 0.05 was considered as significant for all statistical tests. Next, I would like to report research results to you. The first is the patient feature. Altogether, 140 patients with COVID-19 were enrolled. The median age was 44 years, as can be seen from this table. 58.6 were male. The 54 had NAFLD. 7 had positive HBsAg. The median in-hospital days were 18 days. Of the 140 COVID-19 patients, 118 had no CLD and 22 had CLD. Among those with CLD, 3 had cirrhosis, 6 had CHB, and 13 NAFLD had significant fibrosis. 10 NAFLD patients had diabetes as well, compared to those without CLD. Those with CLD were older, with a higher BMI. Those with CLD also had a higher proportion of patients with disease progression. Followed by the incidence of liver injury and the dynamic changes of cytokines. These are profiles of liver enzymes and inflammatory markers in COVID-19 patients. As can be seen from the figure, during the clinical course of COVID-19, liver injury in terms of elevated serum ALT or ALP with GGT was the same among those with CLD as compared to those without CLD. The injury patterns were mainly hepatocellular in each group. No significant difference observed with ALT, AST, ALP, and TBIL between the two groups. IL-6 levels were significantly higher in CLD patients at all 3 time points. Serum ferritin levels were also higher in CLD group at admission and at peak values after admission. The following is to introduction the cause of a patient with ACLF in COVID-19. This is a 79-year-old woman who had NAFLD with fibrosis in the past and denied the history of diabetes. As can be discovered from left pictures, on admission, liver enzymes were normal. Chest X-ray showed multiple patch ground glass opposites in both lungs. On day 6, she had increasingly dyspnea. Chest X-ray showed progression of multiple patch shoulders in both lungs. The patient was transferred to ICU and for IMV and CRRT. We can see that with the progression of the disease, her serum IL-6 and ferritin levels increased rapidly. On the 9th day, the patient's bilirubin increased, reaching the diagnostic standard of ACLF. The liver function deteriorated again on day 16, followed by development of ascites. The patient succumbed on day 22 with multi-organ failure. SARS-CoV-2 sequences were no longer detected in patients' specimen by RT-PCR from day 20 onwards. The bilirubin, INR, and IL-6 levels at the time of death on day 22 were still high. To sum up, draw the following 2 conclusions. First, disease progression is significantly higher in those COVID-19 patients with CLD as compared to those with no CLD. Second, ACLF can also occur in patients with pre-existing compensated CLD who had severe COVID-19. This is the end of my report. Thanks for your attention.
Thank you for a very nice presentation. So any comments or questions from, I'm not sure, Professor Jing Xu, are you available for? You are joining. So very elegant work, and that is complementary to the first presentation by an APASL study, and this is just in time for the the outbreaks of the COVID-19 during the past few years. Any questions from the audience?
First of all, I'd like to congratulate Cui Jing for the very nice presentation. She's just shy. She says her English is not as good, but I think language shouldn't be a problem. The scientific mind is there. The work is done between our groups and in collaborations. And I think it is very important to see that actually the liver injury is more related to the cytokine storms, the IL-6 and ferritin, and it's the dysregulated host immunity against the virus, which actually cause more damage than the virus itself, and how we can modulate. And I think this is the initial understandings at the beginning of the COVID-19 pandemic. Maybe there is any questions from the panelists or the others audience at this point? I think we have a few chats here.
There is no question in the chat.
Yeah, because I think the time is being overrun. Maybe we can close the sessions. And I want to thank the moderators and all the speakers, especially congratulations to the authors of all three publications, which is highly cited in the Hepatology Internationals and has induced a lot of discussions and academic stimulation. So our next sessions for the Hepatology International highlights most cited papers. So on the 29th of December, this year, and the topics will be on viral eliminations. The sessions will be chaired by Professor Omata Sarang, Professor Sarang, and myself. And I hope that we can see you again at that time, which is 3 months down the road. And this is a very important topic on viral eliminations because we want to see how we can link on our APASL efforts to the WHO, the 2030 viral eliminations. So anything to add to Diana and Professor Tawandi?
Well, I indeed learned a lot. I think this is where the expertise of China really matters to us because they were the ones who initially gave out a lot of the strategies we have in the Philippines. So because COVID in the Philippines came in March, and I think they were already doing vaccines as early as that time. And of course, as I mentioned, I hope we will not have again this COVID, but we should be ready for the next one. Thank you. Thank you.
I hope not. Or we back at ourselves better prepared so that we can ameliorate the social, economic, and the health impact, disastrous impact to all of us.
Agree.
Thank you very much.
Thank you, sir.
Shall we close the sessions?
Happy,
Okay. See you very
how do you
soon.
say it? Happy Mooncake Festival?
Yes,
Right?
we have a lot of mooncakes. Okay.
Yeah,
thank
you owe me one, Professor. Thank
Okay,
you.
of course. Anytime, Diana.
Thank you.
Professor Tawandi, thank you very much.
Thank you. Bye-bye.
Thank you very much.
Thank you very much.
Bye-bye, everyone.
Bye-bye.
Hello, APASL colleagues. In 2007, we had a wonderful meeting, I think, in Kyoto. Next year, 2024, therefore, 18 years after, we're going to have the meeting in Kyoto again by the chairmanship of Professor Shina. Professor Shina is the one who did most radiation frequency ablations and cured patients. I worked together with him almost 17 years when I was in Tokyo, University of Tokyo. He was so sincere in terms of treating patients. Therefore, we are very much happy to see all the people from not only the Asia, but from the world together again in Kyoto and then have a successful meeting. I hope you can enjoy not just the meeting, but also the city of Kyoto. Because of the COVID, we cannot see each other. But now we are physically see you and then can interchange all the informations, new knowledges in terms of the patient's care. I really appreciate to have you in Japan.
On behalf of the organizing committee, I am pleased to announce APASL 2024 Kyoto, the Center of Hepatology, scheduled for March 27th to 31st, 2024. We sincerely hope that you will join us with Kyoto's ancient cultural assets and cherry blossoms in full bloom.
The president of APASL 2024 Kyoto, Professor Shuichiro Shina, belongs to the Juntendo University Graduate School of Medicine, Department of Gastroenterology. He is world-renowned as an expert in ablation treatments that are attracting attention.
With the largest population in the world and a 70% concentration of patients with liver diseases in the Asia-Pacific region, APASL 2024 Kyoto, the Center of Hepatology, an important platform for the exchange of cutting-edge knowledge and experience on liver and biliary tract diseases.
With the theme of Center of Hepatology, the main meeting will not only focus on the latest updates regarding liver diseases, but also our mature, time-honored, well-established discourses on hepatology. Distinguished guest speakers and experts from around the world will present, discuss, and share the latest developments in hepatology and related topics.
We encourage you to attend the conference, the largest liver disease conference in the Asia-Pacific region, to obtain the latest information, participate in educational activities, and deepen your understanding of these diseases. After a full day of sessions, Kyoto offers many attractions and venues for you to relax and enjoy.
A wide range of unique venues and World Heritage sites for post-convention programs are available. This city has beautifully blended ancient traditions and modern cityscapes. You can enjoy the mood of bygone days.
We look forward to welcoming you in Kyoto, March 27th to 31st, 2024, when the cherry blossoms will be in full bloom.
I'm Josh Lau, a senior member of the steering committee of APASL. I would like to congratulate Professor Shina, our president of the next APASL annual conference to be conducted in Kyoto, Japan in March. I would like to welcome all of you to the APASL annual meeting. I'm sure Professor Shina and his organizing committee and scientific committee would provide us platforms and another opportunities to exchange our most updated knowledge in liver diseases and to benefit our patients in Asia Pacific region. Thank you very much.